Welcome to the deep dive. Today, we're really digging into some essential reading for spine surgeons, those landmark publications that have, genuinely shaped the way we think and operate.
Absolutely. There's just so much out there. It's overwhelming sometimes. So the goal today is really to extract the key insights, the practical takeaways for you, the listener.
Exactly. We'll be looking at various study types, RCTs, cohorts from the big journals, spine, the Spine Journal, Neurosurgery, NEJM, Lancet, JAMA, high-impact stuff.
Right. Our mission really is to give you a concise but thorough tour of these pivotal papers across different areas of spine surgery. Think of it as a high-yield review.
Okay, let's jump right in. First topic, spinopelvic balance, specifically in L5S1 spondylolisthesis. It's fundamental,
It
really.
really is. And a key paper here is the 2011 narrative review in the European Spine Journal by Labelle, McFarlane, and Rusuli. It's titled Spinopelvic Sagittal Balance of Spondylolisthesis, a Review and Classification.
Okay, Labelle et al. What was the big insight there? It's not just about the slip grade, is it?
Not at all. That's the core message. They used this large database from the Spinal Deformity Study Group and found a strong link between, well, abnormal pelvic anatomy, the sacropelvic morphology, and the overall disturbed sagittal balance in these L5S1 spondy patients.
So the pelvis itself is a key player.
A key player. And based on this, they proposed a classification with 6 types. These aren't just based on the slip grade, but also on the pelvic incidence and the overall spinopelvic alignment.
6 types. And is this classification system actually usable,
Mm.
reliable?
Yeah, that was a strength. They reported substantial intra and inter-observer reliability. So you and I, looking at the same films, would likely classify the patient the same way. It gives us a common language.
That's crucial. And how does knowing the type help clinically?
While they found a correlation between the classification type and the patient's health-related quality of life scores, it underlines that L5S1 spondy isn't just one thing, it's heterogeneous.
So it guides treatment planning.
Exactly. It pushes you to think about restoring the global balance, especially if you're considering reduction techniques for higher grades or in patients with, say, very abnormal pre-op postures. It's about optimizing the mechanics for fusion success.
Got it. So takeaway. Look beyond the slip, assess the whole spinopelvic complex, classify it, and tailor your treatment to restore overall balance. Makes sense.
Precisely.
Okay, let's pivot to thoracolumbar spine trauma. Classification here is obviously vital.
Absolutely essential. And the system that's really gained widespread acceptance is the AO spine classification. This was introduced in that 2013 spine case series by Vaccaro and colleagues. AO spine thoracolumbar spine injury classification system, fracture description, neurological status, and key modifiers.
And Caro et al. What made this one stick compared to older systems like Maygirl or TLICS?
I think it was the focus on simplicity and reproducibility. Previous systems, while valuable, maybe didn't achieve that universal adoption. The AO spine system breaks injuries down into 3 basic morphological types based on the mechanism.
Right, the ABC types.
Exactly. Type A is compression. B involves tension band disruption, think ligaments or bone posteriorly. And C is about translation or displacement. Crucially, the study showed substantial reliability, a kappa score of 0.72, which is pretty good for this kind of system.
Okay, so a reliable, widely used system for trauma. Now, shifting gears slightly within the thoracolumbar spine, what about degenerative conditions, like degenerative spondylolisthesis? That's also quite common.
Very common and also quite variable in presentation. So a helpful classification here is the CARDS classification, proposed by Kepler and colleagues in a 2015 The Spine Journal case series. Clinical and Radiographic Degenerative Spondylolisthesis, CARDS classification.
Cards, what does that help us differentiate?
It aims to provide a simple, clinically useful way to subgroup these DS patients. It defines 4 radiographic subtypes, A, B, C, and D, based on things like disc height, the sagittal alignment, and the amount of translation.
And any other components?
Yes, it also includes a modifier for the severity of leg pain, 0, 1, or 2. Like the AO spine system, this one also demonstrated high and intra-observer reliability in the initial study. Kappa values were actually even higher, around 0.82, 0.83.
Okay, so good reliability again. Having these classifications is great, but how do we actually apply them accurately? Imaging must be key.
Indispensable. And that point was really driven home by Rajasekaran and colleagues in their 2017 European Spine Journal study. The value of CT and MRI and the classification and surgical decision-making among spine surgeons in thoracolumbar spinal injuries.
Rajasekaran et al., what did they emphasize?
They highlighted how critical CT and MRI are for accurately classifying these injuries using systems like AO Spine and then guiding our surgical decisions. CT is, fantastic for the bone, defining that fracture morphology for the ABC classification.
An MRI.
MRI is crucial for the soft tissues, assessing neurological involvement, but especially the integrity of the posterior ligamentous complex, the tension band. That's often what differentiates a B-type injury from an A-type. These imaging findings feed directly into the key modifiers within the classification systems.
Right, the modifiers that influence treatment. So once we've used imaging to classify the injury, say with the AO Spine system, how does that translate into a treatment plan?
Well, the AO Spine Group also developed a surgical algorithm based on a global survey of their members. It uses the thoracolumbar AO Spine Injury Score, or TLAOSIS. This score helps guide decision-making.
What are the thresholds?
Generally, a score of 3 or less points towards non-operative management. A score over 5 suggests surgery is likely needed, and scores of 4 or 5 fall into this sort of equipoise or gray zone where surgeon judgment and other factors really come into play.
Okay, so it provides a framework, a starting point based on consensus.
Exactly. It's a widely accepted framework.
So to summarize this section, for thoracolumbar trauma and degenerative spondy, we now have reliable classification systems like AO Spine and CARDS. Advanced imaging, CT and MRI, is crucial for applying them accurately. And systems like AO Spine come with treatment algorithms based on injury severity scores to help guide initial management decisions.
That's a good summary.
All right, let's move into the OR now and talk about some specific surgical techniques and approaches. Starting with the lumbar spine, minimizing muscle damage is a big theme now, right?
Definitely. Muscle-sparing approaches have become much more prominent. A key paper describing the anatomical basis for some of these is the 2010 Neurosurgery Technical Note by Ho, Wang, and Ritland. Anatomic features of the paramedian muscle-splitting approaches to the lumbar spine.
Ho, Wang, and Ritland. What's the principle behind these muscle-splitting approaches?
Well, splitting might even be a bit of a misnomer. It's more about dissecting between muscle groups using the natural intramuscular planes and separating muscle fascicles rather than cutting across them or stripping them extensively off the bone.
And the benefit for the patient.
The idea is significantly less muscle trauma. This aims to preserve the muscle's blood supply and innervation, leading to potentially less blood loss during surgery, less post-op muscle atrophy, and maybe less chronic back pain related to muscle injury. These approaches can be used for decompression, discectomy, even fusion with pedicle screws.
Okay, interesting now. Shifting way up to the top of the spine, C1, C2 fixation. That's always a technical challenge.
It certainly is, and a major advance here was described by Harms and Melcher in their 2001 Spine Technical Note. Posterior C1, C2 fusion with polyaxial screw and rod fixation.
The Harms technique. What problems with older methods did it solve?
Older techniques like wiring or even transarticular screws had limitations. Wiring could be less rigid, and transarticular screws, while effective, have a demanding trajectory with risk to the vertebral artery and sometimes make anatomical reduction difficult.
So how does the Harms technique work?
It uses polyaxial screws placed individually into the C1 lateral mass and the C2 pedicle or pars. These are then connected by rods. The polyaxiality gives you flexibility in screw placement, and the rod allows for controlled reduction of any C1, C2 misalignment.
Advantages.
It generally provides very rigid fixation, avoids the need for structural bone graft in many cases, allows for anatomical reduction, and the reported initial results showed high fusion rates with low neurological or vascular complications related to the screws. You can even potentially remove the hardware later in some select cases.
A real game changer for C1, C2 instability. Okay, back down to the lumbar spine. Let's talk about TLIF, transforaminal lumbar interbody fusion.
A real workhorse procedure for many surgeons. An early important paper looking at its use was the 2001 Neurosurgery Retrospective Cohort Study by Rosenberg and Moumani, Transforaminal Lumbar Interbody Fusion, Technique, Complications, and Early Results.
What did this early look at TLIF show?
They reviewed 22 patients, mostly with low-grade spondylolisthesis, who had TLIF with pedicle screws. They detailed the technique, the unilateral approach for decompression, discectomy, end plate prep, cage insertion for height and lordosis restoration.
And the outcomes.
The early results showed significant pain relief. They did report some complications, durotomies, infections, some transient nerve issues, which is important, but the conclusion was that TLIF with screws was a safe and effective way to get a circumferential fusion through a single posterior approach.
Okay, so summing up techniques. We see a move towards muscle-sparing lumbar approaches, a more reliable and adaptable C1-C2 fixation method with the HARMS technique, and early validation of TLIF as a solid option for lumbar fusion.
That covers some key technical advances.
Now, a crucial long-term consideration after fusion surgery, especially in the neck, adjacent segment disease, or ASD.
Yes, something we always have to counsel patients about. A landmark paper on this after ACDF is the 1999 The Journal of Bone and Joint Surgery retrospective cohort by Hillebrand and colleagues. Symptomatic adjacent segment disease after anterior ventral cervical arthrodesis?
Hillebrand et al. What did their long-term follow-up find? It's a real risk, isn't it?
It is. They followed over 400 ACDFs for up to 21 years. They found a pretty consistent annual incidence of symptomatic ASD, around 2.9% per year. They projected that over 25% of patients would develop symptomatic ASD within 10 years of their initial ACDF.
Wow. 1 in 4 within a decade. Any levels more at risk?
Yes, they identified higher risk at C5, C6, and C6, C7, the levels adjacent to the most commonly fused segments. Interestingly, they found a lower risk after multi-level fusion compared to single-level, which is a bit counterintuitive.
Huh. And what happens when patients develop symptomatic ASD?
Well, over 2/3 of the patients in their study who developed symptomatic ASD ended up needing additional surgery, so it's a significant clinical issue with long-term implications.
Definitely something patients need to understand up front. Okay, now let's shift to a major area. Comparing surgical versus non-surgical treatments, particularly in the lumbar spine. We need good evidence here.
Absolutely, and randomized controlled trials, RCTs, are the gold standard. Let's start with chronic low back pain. The 2001 Volvo Award winner, published in Spine by Fritzl et al. From the Swedish Lumbar Spine Study Group, is key. Lumbar fusion versus non-surgical treatment for chronic low back pain, a multi-center randomized controlled trial.
Fritzl et al. Fusion versus non-op for chronic low back pain. What did this RCT show?
They randomized almost 300 patients with severe chronic low back pain to either fusion surgery or a structured non-surgical program. At 2 years, the surgical group showed significantly better results, less back pain, less disability, and more patients rated themselves as better or much better.
What about returning to work?
Also significantly higher in the surgical group. Now, they did report an early complication rate of 17% with surgery, which isn't trivial, but the conclusion was that for carefully selected, well-informed patients, fusion could be more effective than non-surgical care.
Okay, so a potential benefit for a select group. What about lumbar spinal stenosis? The SPORT trial comes to mind.
Yes, the Spine Patient Outcomes Research Trial, or SPORT, provided crucial data. The main results comparing surgery to non-surgical therapy were published in NEJM in 2008 by Weinstein et al. Surgical versus non-surgical therapy for lumbar spinal stenosis. This included both randomized and observational arms.
What did SPORT tell us about surgery for stenosis?
Well, the intention to treat analysis in the randomized group was a bit muddied by high crossover rates. But the as-treated analysis, combining both cohorts based on the treatment actually received, showed a clear advantage for surgery.
In what outcomes?
Significantly greater improvement in bodily pain, physical function, and disability scores at both 3 months and 2 years for those who had surgery compared to those treated non-surgically.
So surgery works well for stenosis. But the question often is, do we need to add fusion to the decompression?
That's the critical question addressed by First et al. In their 2016 NEJM RCT, a randomized controlled trial of fusion surgery for lumbar spinal stenosis. They compared decompression alone versus decompression plus fusion in stenosis patients, some with and some without degenerative spondylolisthesis.
First et al. What did they find about the added value of fusion?
This was quite impactful. They found no significant difference in the primary outcomes, the Oswestry Disability Index, ODI, or the 6-minute walk test between the two groups at either 2 years or even 5 years follow-up.
No difference in outcomes, but differences in the surgery itself.
Big differences. The fusion group had longer operating times, more blood loss, longer hospital stays, and significantly higher costs. Reoperation rates were similar, so the conclusion was pretty stark. Adding fusion didn't seem to provide better clinical outcomes in this population.
That's really important for practice, potentially avoiding the morbidity and cost of fusion if decompression alone is sufficient. Okay, let's look at another common diagnosis. Lumbar disc herniation. back to sport.
Yes, sports also tackled lumbar disc herniation. The 4-year results comparing surgery versus non-operative treatment were published by Weinstein et al. In Spine in 2008. Surgical versus non-operative treatment for lumbar disc herniation.
And the findings for disc herniation, similar to stenosis.
Again, looking at the as-treated analysis, surgery came out ahead. Patients who underwent surgery had significantly greater improvements in pain, function, and disability compared to the non-operative group at the 4-year mark. Interestingly, the percentage working was similar between groups.
And do these benefits hold up long-term?
They seem to. Lurie et al. Published the 8-year sport results for disc herniation in spine in 2014. 8-year results for the spine patient outcomes research trial. This follow-up confirmed the significant surgical treatment effects for pain, function, and disability, and importantly, showed little decline in outcomes for either group between years 4 and 8.
So, strong, sustained evidence for surgery's benefit in lumbar disc herniation for the right patients. Now let's loop back to degenerative spondylolisthesis, specifically with stenosis. We talked about first finding no benefit for adding fusion, but what about earlier studies?
Right, the picture is a bit more complex if you look historically. An early prospective cohort study by Herkovitz and Kurz in the Journal of Bone and Joint Surgery in 1991, degenerative lumbar spondylolisthesis with spinal stenosis, compared decompression alone versus decompression plus non-instrumented fusion, an intertransverse process arthrodesis.
Non-instrumented fusion, what did they find?
At about 3 years follow-up, they reported significantly better pain relief, both back and leg pain, in the group that received the arthrodesis compared to decompression alone.
Okay, so that suggested a benefit for fusion, albeit non-instrumented. But can decompression alone ever be enough for degenerative spondy?
That question was explored in a 2016 systematic review by Wakaman et al. In Clinical Spine Surgery. Is there a role for decompression alone for treating symptomatic degenerative lumbar spondylolisthesis? They reviewed the literature to identify factors associated with poor outcomes after decompression alone.
What factors did they identify?
Things like significant facet joint orientation issues, facet angle 50 degrees, preserved disc height, predominant low back pain, signs of instability or hypermobility on imaging, or if extensive posterior element resection was needed. They suggested that while short-term outcomes might be similar between decompression alone and fusion, fusion might hold up better long-term. But they concluded decompression alone could be sufficient in carefully selected patients without those risk factors.
So patient selection is key if considering decompression alone. But what about instrumented fusion versus decompression alone in this group?
Another important RCT, this one by Deo et al., published in the Journal of Bone and Joint Surgery in 2005. Degenerative lumbar spondylolisthesis with spinal stenosis, a prospective randomized study comparing decompression with and without posterior dorsal instrumentation. This looked at grade IDS with stenosis.
Deo et al. Instrumented fusion versus decompression alone. The verdict.
They found that the instrumented fusion group had significantly greater improvement in the SF-36 physical component score, a quality of life measure at 2, 3, and 4 years. The ODI difference wasn't significant. The fusion group, as expected, had more blood loss and longer hospital stays, but interestingly, they had lower reoperation rates.
So maybe better quality of life and fewer reoperations long-term, despite the initial hit. That complicates the picture presented by the first trial.
It does. It suggests there might be nuances depending on the specific patient population, the exact outcomes measured, and maybe the length of follow-up. It's not always a straightforward answer.
Definitely not. And just to round out the stenosis discussion, what about the long-term sport results for stenosis?
The 4-year sports stenosis results, published by Malmafara et al. In Spine in 2007, long-term results of surgical versus non-operative management of lumbar spinal stenosis reinforced the earlier findings. The as-treated analysis showed sustained benefits for surgery in pain, function, and disability at 4 years compared to non-operative care.
Okay, so summarizing this complex outcome section, for chronic low back pain, fusion helps a select group, Fritzl. For stenosis without spondy, surgery is better than non-op, but adding fusion to decompression might not improve outcomes and increases risk costs. First, though some older studies hinted at benefits for fusion, particularly instrumented fusion in DS, Herkovitz, Deo. For disc herniation, surgery provides significant and durable benefits over non-op care, Sport Forgers and HER.
That's a fair summary of a complex landscape. Lots for you, the surgeon, to weigh when talking with patients.
Absolutely. Okay, let's turn our attention fully to the cervical spine now. Trauma management first. What are the key papers for axis fractures?
A classic is the 1985 The Journal of Bone and Joint Surgery case series by Levine and Edwards, The Management of Traumatic Spondylolisthesis of the Axis. This really laid the groundwork for classifying and managing Hangman's fractures.
Levine and Edwards classification. What's the essence of it?
They described 4 types, type 1, 2, abia, and 3, based on the fracture pattern, displacement, and angulation, linking these to the mechanism of injury, like hyperextension versus flexion. They then proposed treatment strategies for each type, ranging from collar immobilization for stable type 1 to traction and halo, or even surgery for unstable type 3 injuries. It remains highly relevant.
A foundational classification. What about reducing cervical dislocations without surgery? Can traction be used aggressively?
Yes, but with extreme caution and expertise. The 1993 Spine Prospective Cohort study by Kotler et al. Closed reduction of traumatic cervical spine dislocation using traction weights up to 140 pounds explored this.
140 pounds. That sounds risky.
It does, and it requires meticulous neurological monitoring in an awake patient. But in their series of 24 patients with facet dislocations without major fractures, they successfully achieved closed reduction in all cases using incrementally increased weight up to that 140-pound maximum without causing any new neurological deficits. It showed it can be done safely in the right hands for the right injury.
Good to know the potential, but emphasizes the need for experience. Now, pediatric spinal trauma. Different, right?
Very different anatomically and biomechanically. Hadley et al.'s 1988 Journal of Neurosurgery case series, Pediatric Spinal Trauma, review of 122 cases, it's a good overview. They highlighted 4 distinct injury patterns seen in kids and how injury types, levels, and neurological outcomes vary with age due to the immature spine's characteristics.
And one specific pediatric entity is Seshwara.
Right. Spinal cord injury without radiographic abnormality. Pang and Pollock's 1989 The Journal of Trauma paper, Spinal cord injury without radiographic abnormality in children, the Sekigahara syndrome, provided detailed profiles of 55 kids with neurological deficits, but no fractures or dislocations on plain x-rays or even tomograms. You have to have a high index of suspicion for it in pediatric trauma.
Okay, back to adults with cervical SCI. The timing of surgery is a big question. Early versus late decompression.
A very important question addressed by the Stasis trial, published by Feelings et al. In PL1 in 2012. Early versus delayed decompression for traumatic cervical spinal cord injury. Results of the surgical timing in acute spinal cord injury study, Stasis.
Stasis. What did this prospective study find?
It was a large, international, multi-center study comparing outcomes after decompression within 24 hours versus later than 24 hours. The results were significant. Patients in the early surgery group, 24 hours, were significantly more likely to have substantial neurological improvement, defined as a 2-grade improvement on the Asia Impairment Scale at 6 months.
So, early decompression seems beneficial.
The evidence strongly supports it, yes. The multivariate analysis confirmed higher odds of improvement with early surgery, and importantly, complication rates were comparable between the groups.
Okay, now let's touch on a controversial topic. Methylprednisolone for acute SCI. There are strong opinions here.
Indeed. The initial push came from the Naskis trials. Naskis II, published by Bracken et al. In NJM in 1990, a randomized controlled trial of methylprednisolone or naloxone, reported that high-dose methylprednisolone given within 8 hours of injury led to significant motor and sensory improvement at 6 months compared to placebo.
That sounds positive, so what's the controversy?
Well, subsequent analyses and critiques, like Hurlbert's 2000 Journal of Neurosurgery narrative review, Methylprednisolone for acute spinal cord injury, an inappropriate standard of care, questioned the findings. Hurlbert argued the primary outcomes weren't actually significant, the benefit was seen only in post-hoc subgroup analyses, and the potential harms of high-dose steroids, infection, bleeding, etc., weren't adequately weighed against this questionable benefit.
So the standard of care status is debated.
Highly debated. Many institutions moved away from mandatory steroid administration based on these critiques and subsequent guideline updates. It's definitely not considered the mandatory standard it once was.
Okay, a nuanced issue. Let's move to surgical fixation challenges in the cervical spine. What about anterior plating for flexion distraction injuries?
There can be issues there. Johnson et al.'s 2005 Spine Retrospective Cohort, the radiographic failure of single-segment anterior ventral cervical plate fixation in traumatic cervical flexion distraction injuries, looked at this. They reviewed patients with facet dislocations or fracture dislocations treated with single-level ACDF and bleeding.
And what did they find?
They found a radiographic failure rate, meaning loss of alignment, of about 13%. This failure correlated with having associated end plate compression fractures or facet fractures on the initial films. It suggests that in these specific, more unstable flexion distraction patterns, a single level anterior plate might not be sufficient on its own.
So you might need posterior fixation as well, or a different approach.
Potentially, yes. It raises concern about the mechanical stability of just an anterior construct in those injury types.
What about managing isolated cervical facet fractures?
Yeah.
Operative versus non-operative.
A systematic review by Fogel et al. In Journal of Neurosurgery, Spine in 2016, Cervical Facet Fractures, a systematic review that tackled this. They compared outcomes and found that operative treatment, specifically open reduction and internal fixation, was more successful at maintaining reduction compared to non-operative methods like halo or collar. Interestingly, they also noted anterior approaches seemed better at maintaining reduction than posterior ones for these specific fractures.
So surgery seems favored for maintaining alignment in facet fractures. Okay, let's shift from trauma to chronic cervical conditions. Cervical spondylotic myelopathy, or CSM.
A major focus area. The AO Spine North America CSM study generated several key papers. The study rationale and design were first laid out by Feelings et al. In Spine in 2010. The AO Spine North America Cervical Spondylotic Myelopathy study.
And what about the surgical outcomes from that study?
Ficcaro et al. Published the one-year efficacy and safety results in the Journal of Bone and Joint Surgery in 2013, Efficacy and Safety of Surgical Decompression in Patients with Cervical Spondylotic Myelopathy. This large prospective cohort showed significant improvements in neurological function, MJRA, neuric grade, and quality of life, NDI, SF36, after surgical decompression for CSM. These benefits were seen across all severities of pre-op myelopathy.
Surgery helps, but what about complications?
Also addressed by the AO Spine group, Dekutowski et al. Published the complication analysis in Journal of Neurosurgery, Spine in 2012, Perioperative and Delayed Complications. They reported an overall perioperative 30 days, complication rate around 15–16%, and a delayed up to 2 years, rate around 4–5%. They also identified risk factors like older age, combined anterior-posterior surgery, longer operative times.
Knowing those rates and risks is vital for counseling. What about specific patient groups, like those with rheumatoid arthritis affecting the cervical spine?
That's a challenging population. An early important paper was by Ranawat et al. In the Journal of Bone and Joint Surgery back in 1979, Surgical Outcome of Rheumatoid Arthritis of the Cervical Spine. They reviewed 33 RA patients who needed cervical fusion for instability, like atlanoaxial subluxation or odontoid migration. They developed classifications for pain and neuroinvolvement and found posterior fusion generally yielded better results in their cohort, though complications and mortality were significant concerns.
Highlights the complexity in RA. Finally, in the cervical section, let's revisit odontoid fractures, specifically in the elderly. Type 2 fractures are common and tricky.
Very tricky. The AO Spine North America Geriatric Odontoid Fracture Study provided valuable data. Chapman et al. Published the mortality analysis in Spine in 2013, the AO Spine North America Geriatric Odontoid Fracture Mortality Study. This retrospective study compared operative versus non-operative treatment for type 2 odontoid fractures in patients 65 and older.
Operative versus non-op in the elderly. What did they find regarding mortality?
After adjusting for confounders, their multivariate analysis showed lower 30-day mortality associated with operative treatment. There was also a trend towards lower long-term mortality with surgery. This suggested a potential survival benefit to fixing these fractures surgically in older patients.
What if they are treated non-operatively? What happens if the fracture doesn't heal?
Another analysis from the same AO Spine study by Smith et al., also in Spine in 2013, effective type 2 odontoid fracture non-union on outcome, looked specifically at the non-operatively treated group. They found very high rates of non-union, while the 12-month functional scores, NDI SF36, weren't significantly different between those who healed and those who didn't. Among the survivors who didn't cross over to surgery, the overall high non-union rate and associated mortality really underscore the risks of non-operative treatment for these fractures in the elderly.
So surgery might offer better mortality and union rates, even if short-term function in non-op survivors looks okay on paper.
That seems to be the implication, yes.
Okay. A comprehensive look at the cervical spine. We've covered trauma classifications, Levine-Edwards, reduction techniques, Kotler, pediatric considerations, Hadley, Sierra, SCI timing, Staskis and controversies, steroids, fixation challenges, Johnson, Facet fracture management, Fogel, CSM outcomes and complications, ASI studies, RA challenges, Ranawat, and odontoid fracture management in the elderly AO spine studies.
Let's move to metastatic spine disease.
Right. Managing spinal mets often starts with prognosis. The Tokuhashi score is a well-known tool here. The revised version was presented by Tokuhashi et al. In Spine in 2005, a revised scoring system for preoperative evaluation of metastatic spine tumor prognosis. The Tokuhashi score, how does it help?
It uses 6 parameters: general condition, number of extraspinal bone metastases, number of metastases in the vertebral body, mets to major internal organs, primary cancer site, and neurological status to generate a score out of 15 points. This score correlates well with predicted survival and helps you tailor the aggressiveness of treatment: extensive surgery versus palliative radiation or less invasive options.
A valuable guide. What about when patients present with spinal cord compression from metastases? Surgery versus radiation.
The definitive trial here was by Patchell et al., published in Lancet. Direct decompressive surgical resection in the treatment of spinal cord compression caused by metastatic cancer. This was an RCT comparing direct surgery followed by radiotherapy versus radiotherapy alone.
Patchell et al., what was the outcome?
The trial was actually stopped early because the benefit of surgery was so clear. Significantly more patients in the surgery group were able to walk after treatment, they retained ambulation longer, and even non-ambulatory patients were more likely to regain the ability to walk. They also needed fewer steroids and opioids.
So surgery plus radiation became the standard for epidural spinal cord compression.
Yes, for patients who are suitable surgical candidates with a reasonable prognosis, direct decompression followed by radiation is superior to radiation alone.
Okay. What about less invasive options for pain or instability from METs, maybe without cord compression? Vertebroplasty.
Vertebroplasty emerged as an option here. An early paper showing its potential was by Weil et al. In Radiology in 1996, Spinal Metastases, Indications for and Results of Percutaneous Injection of Acrylic Surgical Cement. They reported on 37 patients, showing good pain relief in most, which was often sustained. It offered a minimally invasive way to stabilize painful metastatic lesions.
And a related procedure, balloon kyphoplasty, for vertebral compression fractures in cancer patients.
Yes, the KHEFI trial, published by Berenson et al. In the Lancet Oncology in 2011, balloon kyphoplasty versus non-surgical fracture management, specifically addressed this. It was an RCT comparing kyphoplasty to non-surgical management for painful VCFs in cancer patients.
The CAFE trial findings.
Kyphoplasty led to significantly faster and greater reduction in disability, measured by the Roland Morris Disability Questionnaire, at 1 month compared to non-surgical care, with low adverse event rates. It showed kyphoplasty is effective and safe for rapidly improving pain and function in this specific group.
So for metastatic disease, use prognostic scores like Tokuhashi, strongly consider surgery plus radiation for cord compression, Patchell, and utilize vertebroplasty or kyphoplasty for pain and stabilization in appropriate cases. Wow, CAFE.
That covers the main approaches.
All right, let's tackle thoracolumbar burst fractures specifically. Operative versus non-operative management is a recurring theme.
It is. A key RCT here was by Wood et al., published in Spine in 2003. Operative versus non-operative treatment of stable thoracolumbar burst fractures. This looked at stable burst fractures without neurodeficits.
Wood et al. Stable burst fractures. Surgery or no surgery?
With about 44 months follow-up, they found no significant difference in return to work or average pain scores between the operative fusion with instrumentation and non-operative cast or brace groups. In fact, the non-operative group reported slightly less disability and complication rates were higher with surgery.
So for stable fractures, non-op looks pretty good.
It certainly seemed to hold its own, suggesting surgery didn't offer a major long-term advantage in this stable group.
What about the very long-term natural history of these stable burst fractures treated non-operatively?
Another relevant study is by Cossom et al. In Spine 2004. The Natural History of Stable Thoracolumbar Burst Fractures, a prospective 6-year follow-up study. They followed non-operatively treated stable burst fracture patients for 6 years.
And what did they find after 6 years?
Most patients actually did quite well functionally and had reasonable pain control. Some did have progression of their kyphosis over time, but interestingly, the amount of kyphosis didn't strongly correlate with their pain or function. It adds further support to non-operative management being a viable long-term strategy.
Okay, and if we treat non-operatively, is bracing necessary?
That's another common question. Bailey et al. Addressed this in an RCT interim analysis published in Journal of Neurosurgery, Spine in 2009. Thoracolumbar burst fractures treated with and without TLSO. They compared TLSO bracing versus no bracing for stable AO type A3 burst fractures, no ligament injury, no neurodeficit.
Brace versus no brace for stable burst fractures. The result?
At the 3-month interim analysis, there was no significant difference in any outcome measure between the groups. Failure rates requiring surgery were low and similar in both arms. The authors suggested bracing might not be necessary for these specific stable injuries.
So for stable thoracolumbar burst fractures without neurodeficit, non-operative treatment often yields similar long-term outcomes to surgery, potentially with fewer complications. Wood, Jison, and routine bracing may not even be required, Bailey.
That's a good synthesis of the evidence for stable patterns.
Finally, let's discuss one more classification system focused on predicting hardware failure after posterior fixation.
Right, that's the load-sharing classification described by McCormack et al. In Spine back in 1994. The load-sharing classification of spine fractures.
McCormack load-sharing classification. What does it predict?
It was developed specifically to predict the risk of pedicle screw breakage when using short segment posterior fixation for 3-column thoracolumbar injuries, like severe burst fractures. They found screw fractures correlated with more severe vertebral body comminution and damage.
How does it work? What does it score?
It's a point system based on 3 factors: the amount of vertebral body comminution, how smashed the body is, the spread or displacement of the fracture fragments within the spinal canal, and the degree of kyphotic deformity correction achieved surgically. A higher total score means the fractured vertebra is less able to share axial load, putting more stress on the posterior implants.
And the clinical relevance. How do you use this score?
You can use it preoperatively or intraoperatively to estimate the risk of short segment construct failure. A high score, typically 7 or more, suggests that short segment posterior fixation alone might be insufficient, and you should consider alternatives like longer segment fixation, anterior column support like a cage or strut graft, or perhaps augmentation techniques to reduce the risk of hardware failure.
So a practical tool to guide instrumentation strategy and potentially prevent complications.
Exactly. It helps you identify those cases at higher risk for implant failure where just posterior screws and rods might not be enough.
Excellent. Well, that brings us to the end of our tour through these landmark publications. We've covered a lot of ground.
We certainly have. From foundational classifications and understanding spinopelvic balance, through trauma management, surgical techniques, comparative effectiveness trials, and managing specific conditions like metastases and complex fractures.
It really underscores how much the field relies on this kind of evidence and how important it is for all of us, for you, the listener, to stay informed.
Absolutely. These studies provide the basis for so many of our clinical decisions, even if new evidence continues to refine our approaches.
Hopefully this deep dive has served as a useful refresher or perhaps introduced you to some key papers you weren't as familiar with. It's really just a foundation, of course.
A foundation for further reading and critical thinking about how these findings apply to your own practice.
So as a final thought to leave you with, considering the sometimes conflicting, sometimes concerning findings across these diverse studies, from the benefits of surgery in sport to the questions raised about fusion in FIRST, how might these landmark publications, viewed collectively, influence or perhaps even change the way you approach your next complex spine case?
Something to ponder. Thanks for joining us.
Thank you for joining us on The Deep Dive.